we were discussing palliative care, and some of you guys, hopefully all of you guys, saw the email go out that we now have access to palliative care in our hospital. Again, it comes and goes, it seems like, 10 months. So we have access to that again, and the general question was, how do you make the decision to put some money on palliative care or hospice? Remember, they're different terms. Hospice is more for the terminal phase of their terminal course, whereas palliative care could actually be started early in the process of a terminal illness. So if you have somebody there who has fairly well-controlled cancer, but it is terminal, it would be appropriate to get palliative care involved up front. Now, I think it would be very easy to make the argument that probably the primary care and inpatient teams would be doing that, but you would not be out of line, I think, to at least have that talk with them in the emergency department. All right. In terms of hospice, I think that is very much in our wheelhouse. All right. We see those patients all the time. The patient that comes in that's contracted and they're nonverbal and they're not able to get out of bed and have absolutely zero quality of life. That is a no-brainer that hospice or at a minimum palliative care needs to be involved with the care of that patient. And we, I think, need to be doing more of that, getting more of that team involved. Even if the family is unwilling to make that jump to comfort care, you can still consult palliative care and let them talk to the family and let them explain a little bit more about what they do and maybe put some things to rest about, well, they're just not going to care about my loved one if I make that jump. So another thing, too, is kind of a soapbox thing for me is the way that we approach the family when we want to have that discussion. The very common discussion is, if their heart stops, you want us to do everything. And that, in my humble opinion, is just not the way to approach that family. And the reason is because it puts their life or death decision on the family. They feel like if they say, no, I don't want you to do anything, that you are killing they are killing their family member. Okay. The better way to approach it is get them thinking about what their quality of life is. Tell me a little bit about how they spend their day. Well, they just sit in bed. Okay, are they able to hold a conversation? No, they don't talk at all. Do they eat anything? Well, they get fed through that tube in their stomach. What are your thoughts on that quality of life? Do you think that's something that they enjoy? And almost always they're going to say no. They say, well, listen, they are at that stage in their life where they are dying. Okay, they're nearing that. I think it's very important that we change our goals of care, where we keep this patient comfortable. It's not that we're not going to care about them, but we're going to focus on letting nature run its course and keeping them comfortable throughout that process. And you'll be surprised how many times they will buy into that and go along with you because you've convinced them in the right way that that's the right thing to go. You let them know that they're not going to improve from where they are at hospital admission. And that really leaves the door open to get palliative or hospice care involved. And a lot of times you can get the patient home on hospice care if you got easy access to them, and hopefully that's something that'll happen because most people would prefer to die at home. All right, so I think that's something that we can try to give them from the emergency department.
Dr. Shreves just published an amazing lecture on this topic that was given at SMAC this past week on the SMAC podcast feed. I couldn't agree with Rich more. Like we do an abysmal job of talking to folks about end-of-life stuff, and we're on the front lines and we see them. If someone's actively being followed by an oncologist and they're seeing them every week, sometimes it'll be as simple as, I think that you and your family need to talk to the oncology team about changing the goals of care, because they frankly know much more about liver cancer that's stage 3B, whatever. They're going to have a much better idea. But the rough yardstick of, if you would not be surprised if someone's dead within 6 months, then they should be a consideration of hospice care. Maybe it's appropriate, maybe it's not. But if you think they've got less than 6 months to live, there needs to be that conversation. And ironically, people that are referred to hospice actually live longer than people that aren't. So even though you're saying we're going to be maximally aggressive about your comfort as opposed to maximally aggressive about curing you of this disease that we know we can't cure, they actually live longer, have higher quality of lives, cost less money, and everyone is happier. It is an absolute slam dunk, and it is a shame that we don't do it more often. I'm really excited that this is available.